At this time, I would like to introduce Dr. Mohammad Shaker from Ain Shams University, Egypt. He will be talking about building a practice, prostate embolization practice, and how to recruit our patients. Thank you.
Actually, what a difficult task to talk about the prostatic artery embolization after the inventor of the technique, so please appreciate this during my talk. I will give you some hints and ideas about how to build the practice of prostatic artery embolization based on our experience in Egypt. The beginning for me was in guest meeting 2012 in New York. In this meeting, I met Dr. Pesco and Dr. Carnevali, the inventors of the technique. And I remember that Dr. Carnevali in this meeting suggested that prostatic artery embolization would be as popular as uterine artery embolization for uterine fibroids. And after I attended the lectures and sessions for prostatic artery embolization, I became convinced that this technique will be a popular interventional technique and maybe a breakthrough technique. So immediately after returning to Cairo, I started to establish our team in Egypt, and this team is consisting of me and my colleague, Dr. Karim Abtawab, and another urologist friend of us. And we went to Dr. Pesco in Lishpun to learn the tips and tricks of the technique and to know our tools, the tools that we need. And we started to do our first few cases, which were referred by this friend of us, and they were successful cases. But we for sure cannot depend on only one referring physician, and we should do cooperation with more urologists. We need, actually, the urologists in this technique, we need to do a teamwork together. They can help us in preparing the patients for the technique. They can also back us if there is any complications after the embolization. So we thought that there should be some sort of cooperation between us and the urologists. So we went to the urology department and attended their committees and talked to them about the technique, the indications, the contraindications, and how to do the technique. And we just asked from them to send for us the patients who cannot do surgery. And we thought that we can do a teamwork together. This was our perspective about the relation between us and the urologists. But we discovered that we were dreamers and that the urologists have a totally different perspective about the relation between us. Actually, it was not like that, but they refused to send us patients, and they decided that they will fight for preventing us to do this technique. So we decided to seek another way to get our patients, to increase the number of patients, to increase our learning curve, and we decided to target the patient directly through many ways. Through promoting for this technique in our IR clinics, through the media, and through the internet. Concerning promotion through the IR clinic, first, it's very essential for us as IR to have our own clinics, either in a medical center or in a hospital or a separate clinic. And through this clinic, we can promote for any technique, whether the prostatic artery embolization or any other interventional technique. So we used our clinics to promote for this technique. And now we are trying to establish a separate clinic for prostatic artery embolization in one of the famous hospitals in Egypt. Through your clinic, you can use some helpful aids like the flyers, which contains some informative data in a simple way about the technique, the indications, the contraindications, the possible complications, and the most important is to focus on the advantages of the interventional techniques over surgery. The other way is through the media. You can write periodically articles about the technique in a simple way to simplify the technique for the patients, and again focus on the advantages over surgery in the medical page of the newspapers or in the medical journals. And also, you can do this through the medical TV shows, which have a large number of viewers and fans, and this is actually a very important and very effective method. This is very attractive for the patients. But just an advice, don't use the shows that you have direct questions and answers online, because you may have some questions from some urologists online, and this definitely will occur, and I think their questions and the comments will not be that pleasant for you. The other way is to use the internet. You can establish a Facebook page like this. We established this Facebook page about 6 months ago, and we have increasing and large number of likes till now. We receive daily questions from about 10 to 20 patients daily, and if you did this, you should be there every day. You should visit your page every day. You will have questions every day from your patients and should answer these questions to avoid losing these patients. And for sure, you can do a website for the prostate, and this is our under construction website. And I want to tell you that with using all these channels, they are working, and you will have your patients. But it is very slowly progressive. And we have two causes for this slow progress. The first cause is that our number as IR doing this technique is still very few, and so the technique is not that popular, for example, as uterine fibroid embolization, and so we need to increase this number. And the second cause is for sure the fight of the urologists against us to prevent us from doing this technique. You should put your protocol. This is our protocol in our institute. We do pelvic ultrasound with measurement of post-voiding residual urine. We do urine analysis plus or minus culture and sensitivity if there is increased pus cells in urine. We do the PSA total and free over total. We do TRUS, MRI for accurate measurement of the prostatic volume and for exclusion of any suspicious focal lesion. We do the urine flowmetry. We do the IPSS score and questionnaire and the quality of life questionnaire, and we do the routine laboratory investigations before any intervention or transcatheter procedure like the CPC, the renal function, and the coagulation profile. And this is our technique. We start like Dr. Carnevali do by putting the urinary catheter immediately before the procedure and removing it after the procedure. Till the 15th case, this case was a general surgeon, and he refused by any means to put the catheter for fear of infection or trauma, and we were obliged in this case to do it without the catheter. And actually, it was a successful case, and this encouraged us to do the rest of our cases without the catheter, and it is working until now. So you can do with the catheter, like Dr. Carnevali, or you can do without the catheter, depending on the anatomy, but maybe somehow difficult, like Dr. Pesco do. We do local anesthesia, unilateral femoral puncture. We catheterize the contralateral side first and then the ipsilateral side. We started by using the Cobra catheter, 5 French catheter, and then we shifted recently to the Rock catheter of Coke, which is very helpful catheter and very stable in these tortuous iliac vessels in this old age. We do the oblique view for sure. We catheterize the anterior division and then do rotational angiography with cone beam CT. And if you don't have cone beam CT in your machine, it is very important or very useful to do a CT angiography before the procedure to know what is the anatomy. And then we catheterize the prostatic artery selectively by prograde catheter and do embolization by BVA particles 150, 250. This movie shows us how to do the technique, the catheterization of the left side, the rotational angiography, then catheterization of the prostatic artery. We do the CT, the cone beam CT. This is the prostatic artery here. And then we catheterize the prostatic artery by the microcatheter, and we go, as Dr. Carnevali said, as distal as possible to avoid any reflux to undesired arteries. Here we are selective in the prostatic artery. supplying the left prostatic loop. And we can see here the anastomosis with the contralateral side, which is a very common finding in these cases. We inject here slowly the PVA particles, very slowly, and this is very important to avoid the complications. And this is a control angiography on the left side after embolization, to be followed by the control angiography. I'll give hints about our short-term results. We have done 22 cases to date, 20 cases of bilateral embolization and 2 cases of unilateral embolization. All cases were technically successful, and we have just finished our first study about our first 14 cases, which we have followed them up for more than 6 months. Rest of cases are done during the last 6 months, so they are still under follow-up. The mean IPSS score before prostatic artery embolization was 24.7, and 6 months later was 12.4 with significant p-value. Mean prostatic volume before prostatic artery embolization by MRI was 84.6, and 6 months later became 52 with a mean volume reduction of about 38%. And the mean post-voiding residual urine before prostatic artery embolization was about 78 ml, and it decreased gradually over the following months and reached, after 6 months, about 8 ml. Mean Qmax before prostatic artery embolization was about 12, and 6 months later, it became 17 with significant p-value. We didn't face any major complications. We have only one complication in the form of fungal cystitis and prostatitis, which resolved on medical treatment and by insertion of suprapubic cystostomy in the bladder. To conclude, prostatic artery embolization is a breakthrough interventional technique suggested to be popular as uterine artery embolization and may replace TURP someday. Prostatic artery embolization is a feasible, safe, and highly effective technique. However, very challenging technique because we do this technique in old patients with atherosclerotic arteries, atherosclerotic plaques, and it may take a very long time and needs superior angiography machine and expert hands. We need to increase the number of IR doing this technique to make it more popular and increase the awareness of patients, thus increasing the support in our battle with the urologists. Thank you.